Not all white cataracts are the same. And my disclosure is I run CataractCoach.com, a free teaching website. So what are the main questions for white cataracts? Number 1, is it intumescent or fluid-filled? Number 2, is it dense or soft? And number 3, what are the associated issues going on? The color can tell us how much of the cortex is liquefied. If it's white to bluish, it's more liquefied cortex, and yellowish is less. So here's the bluish tint, and you can see these are pearl looking, and they're so white that they're blue, and these have liquefied lens cortex, which pressurizes the capsular bag, and that poses a risk of the Argentinian flag sign, and that's where the capsule runs out uncontrolled, and you end up with this situation, which is quite the challenge. On the other end of the spectrum, we have the yellowish tinted lenses. These are less liquefied, and if you look at the periphery of the lens, you can even see a little bit of a darkness there. That's okay. This means the cortex is not as liquefied. These are more dense. Associated abnormalities can be here in figure A, traumatic cataract, zonal loss. B, the whole nucleus is in the anterior chamber. C, this patient has zonular weakness and loss, maybe even coloboma. And D, a patient with aniridia. So there can be associated abnormalities with dense cataracts. That's unusual. It's only about 1 in 20, and the remaining are about half of them are soft and whitish bluish, and half of them are more dense cataracts. So here's a lens. We put in the viscoelastic, and we can see there was movement of the cortex. We've sped the videos up here, so making the incision, this is going to be a difficult time controlling the capsulorhexis. If we just do our usual technique of capsulorhexis creation, you can see here it's going to start to run out, and we have to pull, do that little maneuver, and rescue the rexus. And even here, as we try to finish the rexus, it still wants to run out, and we have to pull it tangentially. So there's a better way than that. We'll continue this case and remove the lens. I'm going to show you my preferred technique here is a variation of chop. So buzzing in the nucleus, and just chop, chop, and more chop. These are dense, and they have a thick posterior plate, which you have to split. But by taking your time and chopping it into mini pieces, this can be removed relatively easily. Here's what we do with our residents. We're using a needle, 27 gauge, to poke in the lens capsule and aspirate. Notice it was done before the main incision, while the AC was just full of viscoelastic, and we do it before the main incision so that the AC pressure is very high. If the pressure in the anterior chamber is higher than the pressure within the capsular bag, you won't get lens capsule extension. What about a fibrotic or wrinkled lens capsule? So here's a patient. You can see there's a big wrinkle and fibrotic area that you can't tear through, so you have to use the scissors to create a little bit of a capsular opening. And when it gets stuck again, we'll use the cystotome for countertraction and to cut as we pull with the forceps. So adding more viscoelastic, bringing this around, and even at the very end, we have to cut that capsule with that. So you say, what about a femtosecond laser? I like those. Well, here's a good case where we used a femtosecond laser for the capsulorhexis, but in this white intumescent cataract, that was insufficient. So you'll see the capsule is still adherent, but we'll use our forceps and pull it centrally and help release those tags. There are the tags 1 and 2. There's the complete rexus. Here's my preferred technique, the double capsulorhexis technique. So with just the side port, the AC highly pressurized, go in there with the cystotome and just create a small baby-sized capsulorhexis. With the AC very highly pressurized and no main incision yet, the lens milk or cortex won't come out that much. It'll stay within the capsular bag. Now that the rexus is complete, we can rock that nucleus around. Now make the main incision. The risk of radialization now is none because we have a round, intact, continuous capsulorhexis. So at this point, now we've depressurized the capsular bag, we can now expand that and create a normal-sized capsulorhexis. So double rexus technique, and that's going to allow us to depressurize the capsular bag and released all that pent-up liquefied lens cortex prior to creating the large capsulorhexis. So by doing it with just that smaller rhexis, it's safety. Now there can be a lot of milk coming out of these lenses. And here's an example with a resident where again and again and again we keep injecting viscoelastic and we're trying to release as much of that fluid as we can. And we'll continue here, finally get the capsulorhexis done. We've depressurized the bag. So much viscoelastic is stuck in the anterior chamber in the viscoelastic. Use more viscoelastic. Remember, viscoelastic is cheaper than vitreous, so use all you want. Finishing it up there, that looks great. So here's, again, the preferred technique is a chop technique. This is a resident performing phaco chop on a white cataract. You can see the double camera angles there. This is a very efficient way to break up the nucleus, including that dense posterior plate. So taking his time, he's doing a fantastic job. This is a senior resident with about 250, 300 cataracts under his belt. So nice chop technique there, works great. And certainly if a resident can do this, anyone in practice can do it as well. It just takes a little bit of a concerted effort and a very easy learning curve. And that nucleus is removed quite easily, and this case is done. So finally here, my normal technique, this is me chopping it right off the bat, a vertical chop, chopping it again, and chop, chop, and more chop. And by using this chop technique, we can really emulsify the nucleus in a very efficient manner, and you can take these patients from white cataracts to normal vision in the course of your surgery. Beautiful. It's an honor to help these patients. Thank you for your attention, and check out CataractCoach.com, our free teaching website, and we got a new video every day. Almost 1,000 videos to date. CataractCoach.com. Dense, brunescent, and white cataract. We're going to show you a complete case from start to finish. It's a tough one. The liquefied lens cortex has been absorbed, so the lens capsule contracts, and you see this gap between the iris and the cataract on your pre-op testing. So here we are in the operating room. There's the eye. We make our paracentesis. You can see this is clearly a very dense cataract. This patient has neglected having cataract surgery for many years. As a result, we have this very dense brunescent cataract, but also features of a white cataract. So we'll use trypan blue dye here to stain the anterior lens capsule. And now we're going to dilute that down with some anesthetics with preservative-free lidocaine that's been cut 50-50 with bounce salt solution. So that's a pretty good staining of the capsule. A little bit more dye leaks out from behind the iris. We'll do an exchange here and fill the eye with our dispersive viscoelastic. So that's a nice good fill. We see we have a good dilation as well. That's going to be important. We're going to make our main incision here. It's 2.4 millimeters using a steel keratome. That looks great. And now it's time for the capsulorhexis. Important in a dense cataract, do not make a small capsulorhexis. We need to have a sufficiently large one. So I want to aim for about a 5 to 5.5 millimeter rhexis. We grab the lens capsule and we start doing our rhexis. There's the measurement. As we see, there's no milk that comes out. There is no intumescent nature to this cataract. There's no fluid that's coming out. The fluid that happened from the liquefied cortex has been absorbed over the last few years. As a result, this is just a dense cataract. There we go. Nice, sufficiently round rhexis. We can measure again. That's about 5 to 5.5 millimeters, and it looks pretty round. Be very cautious with hydrodissection. You see, I first try to rotate without hydrodissection, then just do a bare minimum amount. You can't see the fluid waves go across, so you have to be very careful. Just do a little bit, and that's a sufficient rotation. That looks great. Be very cautious with the hydrodissection. A little more viscoelastic to protect the cornea. Now it's time for phaco. We're going to try to chop this nucleus, and it's going to be difficult to propagate the chop. Let me show you. Buzz in with the phaco probe, we place our chopper on the equator, and we bring them together, and we just can't get a full chop. It won't happen. Try again. So again, a horizontal chop here, buzz in, chopper going around. There's that dense central endonucleus, and still unable to really get a normal chop. So now we're going to have to resort to a more aggressive maneuver here. We're just getting the nucleus tilted on its side, and really trapping that nucleus between the probe and the chopper, and we can exert a tremendous force to bring the two instruments together and then apart, and even then it's still not a complete crack. So this cataract is not just dense, it's fibrous, or leathery is sometimes an adjective people use to describe it. So the best move here is to just break off small pieces and just chip away at it. So here's one more small piece broken off, and then we can emulsify that. We're trying to operate at about the iris plane. So I'll buzz it again, and let's just break off a small piece. So we just do it systematically, piece by piece. You can also do an SICS surgery, small incision cataract surgery, or manual extraction. Of course, that's going to require a much larger incision. This is a 2.4 millimeter incision. Doing SICS is going to require an incision that's many times larger. And for optimal results and best astigmatism, if you did the manual approach, you'd end up needing at least a stitch or two. So here we go. We've got about half the nucleus out, buzzing in again, and you can see the systematic approach is just taking our time. But we want to have that nucleus on its side, so then I can easily trap the nucleus between the phacoprobe and the chopper, and I can exert a much higher force. In normal chopping, only the vacuum, the high vacuum of the phacoprobe of 500 or 600 millimeters of mercury, that vacuum is what's holding the nucleus while the chopper disassembles the nucleus. So in here, though, that's not enough, because we need much more force than that just to try break this into pieces. I mean, look at the concerted effort we're doing here. So by trapping the piece of nucleus, this big nuclear piece between the probe and the chopper, now I'm holding it together with opposing forces, and the piece can't go anywhere. So I can have a much better and more forceful grip than if I just used the 500 millimeters of mercury vacuum. So that's the technique that we like to employ here. So almost done. There's the last densest piece of the endonucleus that comes out. There are a couple of big epinuclear pieces that are softer. Those come out pretty quickly and easily. There's that last one. And boy, what a difference. We finally have a red reflex. Also careful to make sure that we gave energy in bursts. And we're careful not to put too much energy in the eye. Of course, that damages the endothelium, but also you can get a corneal wound burn. And of course, in this case, we were very careful and deliberate, and we avoided any of those issues. So removing the cortex here, there's not going to be a whole lot of cortex, so a little bit of capsule polishing. Again, the best answer here is to be conservative. Very aggressive capsule polishing may damage this capsule. You can have areas of capsule that have been stained by that previously liquefied cortex, and you may not be able to remove all those tiny little opacities. That's okay. The central visual axis is very clear, and that's of no consequence. Let's fill our capsular bag here. In this patient, we're going to put a single-piece monofocal acrylic lens, hydrophobic one. In the pre-op examination, we were unable to use optical methods to determine the axial length, so we had to use an A-scan ultrasound. A little bit less accurate, but still in this case, we're able to get a pretty good result. There's the lens being placed in the capsular bag, and we're going to adjust its position, make sure that it completely unfolds, and get both those haptics opened up. You'll also see that the capsulorhexis we created was just about perfect. It's about 5.5 millimeters. We have complete overlap of the optic for 360 degrees. Now all that's left to do is go inside the eye, remove our viscoelastic, and we will finish up the case. I think it's important for younger surgeons and surgeons with less experience to see cases completed in their entirety. I know it's a full 7.5 minutes of your time, but I think it's an investment that's worth it to see that you can conquer even these very difficult cases very efficiently and very safely. And so we're going to try to feature more of these cases where we do a complete case, unedited, start to finish, to show you all the little details in every single step. Thank you for watching, and I hope you now have the confidence to tackle this type of cataract in the near future. If you want to learn even more, CataractCoach.com is our teaching website. You can join our free email list. It'll send you a new video every single day right to your inbox. Don't have to hunt for it. And it's a lot easier to search through these videos on CataractCoach.com than it is here on YouTube. Thanks for watching. CataractCoach.com. Capsule Rip in less than 1 second. This is how to successfully recover from this capsular rip. So here's a video of Willie Kant from Malaysia showing us a beautiful technique of using a needle to decompress these intumescent white cataracts. So entering there, decompressing it, taking out that intumescent fluid, and now a normal capsulorhexis can be completed. So that's how it should be done. But this case is going to be a little different. Let me show you our case. Now we zoom in here. Patient's about 30 years old, diabetic white cataract. And here's what's different. We filled the eye with viscoelastic, and if I touch, look how pressurized that anterior capsule is. This capsular bag is totally pressurized. Now, there's not a layer of fluid like we normally see here. Normally, you'd have an endonucleus that's solid, surrounded by intumescent fluid. But in this case, what we have is all of the fibers are swollen. So we're getting the eye pressure high. We hopefully want to have a very high pressure in the anterior chamber. We're going to poke in with the needle now and quickly aspirate, and let's see if we can achieve that same technique here. Now we just have that one incision. We poke in and boom. Oh my goodness. What has happened? Where's the fluid? All the fibers are swollen. Wow, it's still swollen. Let's look at 1/4 speed. As soon as that needle touches that lens capsule, it rips uncontrollably. That's how pressurized it was. That's tough. Let's look at 1/10 speed. Just as soon as it enters, it's done. You can't even control it. So what could we have done differently? Maybe used an alternate device to make a capsular opening, buzz in with a phaco probe, use a femtosecond laser, use some other plasma cutting device. A lot of options here, but even those may not have worked. So now we'll go in here, cutting with the scissors, and we're going to try create the remainder of the capsulorhexis here. And you can see it still wants to run out. We're having to pull it in quite a bit just to help control it. So there we go. Now we want to make very careful, be very sure that we don't cause that rip on the capsule to extend to the posterior capsule, because that'll be an issue. Now the lens is soft. We're going with just the IA probe to aspirate the material out. Now, could we have placed the needle on the IA probe and then go in there aspirating? Yes, but you may have had the same issue because you may not have been able to decompress that lens fast enough to prevent that capsule rip, which happened in much less than 1 second. So all the lens material comes out pretty easily. Spending a little bit of extra time here cleaning up any of the residual lens cortex, being very cautious. Okay to do a YAG laser at another point in time in the future, but let's not damage the bag anymore. So there's the cohesive viscoelastic filling up the capsular bag. Now lens placement. You can do a single piece of lens. You can use a 3-piece lens. The patient's getting a monofocal lens, and we're going to opt for the single piece design. And so we'll place that single piece design here in the capsular bag, and we're going to orient the haptics so that they're in the area of greatest overlap of that capsule. And that's going to be very helpful. So making sure we put this in nice and slowly. Here comes the lens, delivering it in there and opening the haptics. And we don't want to rotate the lens much. Keep it right there. And there we have a nice overlap. You can see there nasally, the top part of your screen there. That looks fantastic. Now, we may have to trim the capsule a little bit more. So we're going to go back in here, take out our viscoelastic. It looks pretty good, but there, just under the phaco probe, maybe there's a little too much of that lens capsule remaining. So we're going to go back and trim that down also. But everything looks pretty reasonable here. This patient's going to have a nice outcome. I'm going to put a little more viscoelastic here to give us some control, and we're going to go and try to cut it with scissors. That's hard to access because it's subincisional. So just use a cystotome, a bent needle, and let's have a little break there in the lens capsule, and then using our forceps, we're going to just trim this off a little bit, just to have a little bit less overlap. That looks pretty darn good. Now let's finally remove all the viscoelastic, wash out a little bit of lens material, and we can close this case up. So beautiful outcome at the end here, but wow, what an unusual case. I think the big differentiator here is that instead of having a layer of milky intumescent fluid, the whole lens was just super swollen and highly pressurized. And we saw that at the very beginning, prior to even starting. When we touched the anterior lens capsule with the 27 gauge blunt cannula, we could tell that it was a very highly pressurized lens capsule. So we'll do this patient's other eye in the near future, and we'll try a different technique, and we'll compare, see what the differences are going to be. So thanks for watching. Check out CataractCoach.com, our free teaching website. Got a ton of great material. Sign up for our free daily email. We'll send you a case just like this every day. And we've got a section especially for ophthalmology residents. If you're doing your training, you need to have the Cataract Coach on your side. CataractCoach.com, resident double Rexus technique. It's a great way to avoid the anterior capsule runout. And let's show you the case here. So it's a senior resident doing this case. We've sped up the whole video to 3 times normal speed so we can get through it all. Trypan blue dye going in the eye, a second paracentesis to make life easy. Let's get a good fill of the viscoelastic. Here's our dispersive viscoelastic. You want a good fill, and you want to get that pressure up. Now, with the cystotome through the other side port, making a small little Rexus. Make that baby Rexus. Now, this is just the first Rexus. And there it is. Now we can rock that nucleus around, and we can release any trapped fluid if there is any. This case doesn't look like there's too much lens milk. But that first Rexus being made only with the cystotome and only via the para, and that's so that we can keep the AC pressure high. The goal is the pressure in the anterior chamber should be higher than the pressure within the capsular bag. So now this Rexus can be enlarged, so nicked there with the forceps, and now the resident can create a nice 5 millimeter Rexus. So let's see how that goes. She is doing a great job here. This resident is one that I admire very much because she worked so incredibly hard to improve her skills. And so this is probably about case 50 or 40 in her training. So there's the Rexus going around nicely, taking time to do a good Rexus. That BSS cannula, the squirt bottle cannula, that's me pointing things out for her, giving her some advice, and finishing it up. That's a really nice looking Rexus. Golly, I like it. So how did I section? Remember, be cautious because you can't see the fluid wave going across. So just a little bit of time, and there the nucleus rotates just fine. So let's see the technique that we're going to use here. So this resident's going to use the phaco probe, making a central trench, looks like. All right, so groove down the middle, maybe a stop and chop technique. Stop and chop, I think, is a very nice, useful technique. It's a great resident thing to learn because then it'll be relatively easy to transition towards straight chop or quick chop. So nice grooving there, nice central groove being made. Notice how the angle is correct. Remember, the cataract's like an M&M candy, thicker in the middle, thinner on the periphery. And let's see the split. Good split. Let's see, is it? Nope, didn't propagate through yet. Nope, then we're going to get some help from the other side. There we go. There's a split. Again, a little bit of fibrous nature to this. Make sure it's fully separated. That was great. That was probably me going through the other side port. And now, here's the first half of the nucleus being brought up. And it's going to be chopped. So again, stop and chop technique. There you go, a little bit of help there to bring that piece up. Now the chopper is going to help break this into smaller pieces, and that can just be emulsified pretty easily. And then the other half, of course, is much easier to chop because there's a lot more working room. So buzz into the phaco probe, bring that piece up, and let's get around the equator, buzz into it. Remember, on the phaco chop, you want to chop at the highest vacuum. So when you start buzzing into the piece and you hear the vacuum go up, you want to have yee chop. You don't want yee chop. Think about what I just said. You want to chop at the highest vacuum, the peak of the vacuum, because that's the most holding power. So when you include on the piece, yee chop. But if you hear the vacuum pitch already starting to drop, yee, you don't want to chop there because you don't have the holding power. So we'll start to feature more videos here with audio. We just have to make sure we do that in an appropriate manner. There are actual laws that govern audio recording versus video recording. Video is actually the easier one to record. And certainly all the patients that we feature here on Cataract Coach have given their consent for videotaping the surgery. So cleaning up the capsular bag pretty nicely. I like this case. I'm going to finish this case up just very smoothly. Nice splitting of that transformer eye handpiece. And now this patient's going to have just a beautiful result. Think about the pre-op acuity. Well, that white cataract patient was probably at best count fingers at a foot, maybe even hand motion. And you've got the ability now to magically give that patient clear vision the next day. That's really a miracle of modern medicine. So this double Rexus technique, an important thing to learn. This case was not too intumescent of the cataract, so there wasn't a lot of lens milk. But remember, those intumescent fluid-filled capsular bags, that's how you get that run out. And you want to avoid that. That's that Argentinian flag side. Here comes the lens going in the eye. Single piece acrylic lens will get that delivered nicely into that capsular bag. And now we can see what size the Rexus was, because we know that's a 6mm optic. Actually, look at the dilation. Looks like the dilation's slightly under 6mm. Maybe that Rexus is just about 5. So very nicely done. Now, should you spend a lot of time polishing up that capsular bag? Listen, certainly get out as much of the lens material as you can, as many lens epithelial cells as you can. But there's a balance here. Don't break the capsular bag. And just think of the patient's delta, the difference between the before and after vision. If there's a little bit of capsular haze there on the anterior capsular rim, I assure you that will not diminish this patient's happiness or satisfaction in any way. And when you're learning, we can save some things for further along in the bell curve of learning. So, very nice case. Appreciate this resident for doing a beautiful job. And remember the double Rexus technique for intumescent white cataracts. Thanks for watching these videos. And remember to go to CataractCoach.com and sign up for a free daily email. We'll send you an email every day with a great video like this and other surgical pearls that'll make you a better surgeon. CataractCoach.com. Rock the Nucleus with needle aspiration. This is for those milky white intumescent cataracts. So here's the cataract. You can see it's milky white. It's intumescent, so it's fluid filled. The cortex has liquefied. So we'll put in a trypan blue dye stain right here. That's great. Let's just fast forward a little bit. Diluting the stain now with our anesthetic injection. And then we're going to get a good fill of viscoelastic. We'll put a dispersive viscoelastic to really fill up the anterior chamber and pressurize the anterior chamber. We want the pressure in the AC to be a little higher than the pressure within the capsular bag. That's going to help prevent capsular runout and that dreaded Argentinian flag sign. So here's the viscoelastic going in. It's the dispersive agent. And we want to aim for a pressure of at least 30 millimeters mercury. You can just judge that by touching the cornea. And now what we're going to do is switch over and we'll get a sharp 27 gauge needle on a 3 cc syringe, which is about half filled with balanced salt solution. So that needle can also be slightly bent for easier access. Just make sure that it still flows normally. So there's the needle. We're going to poke into the center of the lens capsule. Right in the center, stab in, and you'll see as soon as we poke in, milk will come out. That's the lens milk, the liquefied cortex. And then we aspirate. And we can aspirate a lot of that liquid. Now, here's where you have to continue. So we aspirated some of it, but that's just the anterior liquefied cortex. There's more behind the lens nucleus. So to access that, we go back inside the eye, go in the whole opening we've made, rock the nucleus back and forth to release more of that milky fluid, and now re-aspirate. This has now really and completely depressurized the capsular bag, and we can proceed with the rest of the case relatively normally. And we've really minimized that risk of an Argentinian flag sign. Let's look at the diagrams. There's the nucleus, which is very dense. It's surrounded by liquefied cortex all around because all the cortex is liquefied. When we poke in with the needle, lens milk comes out because the pressure in the bag is high. And then we'll start to aspirate using that syringe, pulling back on it. We'll get out all that anterior liquefied cortex, and the nucleus then moves up and blocks the flow. So we need to rock that nucleus back and forth to help release all of the liquefied cortex from even behind the nucleus. Now the capsular bag is completely depressurized and all the liquefied cortex is fully removed. It's much easier to proceed with the case now. So now that we've removed all that liquefied lens cortex, we can make the incision here and do the capsulorhexis. So the incision is being made. We've of course sped up this video, and you'll see it's complete control during capsulorhexis creation. The resident's able to create a very nice capsulorhexis without any issues here. So grabbing here with the forceps, bringing it around, and there's no pressure to push towards the zonules like normally you'd have this Rexus wanting to run out because the posterior pressure of the nucleus due to the liquefied cortex that was trapped. But we removed all that. So now let's just fast forward to the end of the case here. The resident will chop the nucleus into many pieces and aspirate it down, and the rest of the case just goes beautifully. So this chop technique is very easy to perform in a white cataract because the visualization is great. The blue dye shows you the capsule edge, and then the nucleus is very white. Here's the end of the case, lens in the capsular bag. That looks great. This patient's going to be really happy. So remember, intumescent white cataract, rock that nucleus. And check out CataractCoach.com. If you're a resident, there's a whole section there right on the front page that gives you the key videos for every year of residency. 10 brief videos that'll make you a much better surgeon. Check it out. CataractCoach.com. Techniques for white cataracts, and specifically intumescent white cataracts. So look at this first case. Very pressurized capsular bag. As we touch the anterior capsule, you can see just how bouncy that is. So the pressure in the capsular bag is very high. So I want to increase the pressure in the AC. So I want the pressure in the AC higher than the pressure in the bag. Now I'll put a needle in to decompress it, and there you go. Don't you feel better? Of course not. So that was tough. So what are the other options here? Well, we can buzz in with the phaco probe to quickly create a small opening, and we can aspirate with the probe and get out some of the liquefied lens cortex. And then what we can do is we can then use a cystotome through the side port and create a small Rexus. So we'll do the double Rexus technique. So the phaco probe's still in the eye because it's pressurized. You can set the infusion pressure to 80 or 90 millimeters of mercury, and that's going to help prevent that from running out. Now we're just trying to create a capsulotomy or capsulorhexis that's small. It can be irregular, it doesn't have to be centered. We just want to get it done. And so I'm almost able to finish this here, but let's try again. This one viscoelastic, and we'll quickly just finish that. There you go. You see how it wanted to run out. Now we can just decompress and just get out all that liquefied lens material. And then we're going to re-enlarge that capsulorhexis. So the challenge in an intumescent white cataract, right? Intumescent's fluid-filled, and that means that the cortex has become liquefied. And as it does that, it pressurizes the capsular bag. And when the pressure in the capsular bag is higher than the anterior chamber pressure, that's when you're most likely to get that Argentinian flag sign where that capsulorhexis just runs out. So what we can do is, in this case, we have a small Rexus that we made initially, and now we can put the lens in and we can enlarge this capsulorhexis. So I'm going to show you more videos here. The double capsulorhexis technique is making one small capsular opening initially and then enlarging it. You can enlarge it after decompressing the cataract. If you have a denser cataract, or in a case like this where the cataract was less dense, we can enlarge it now after the IOL is placed in the capsular bag. And say we can just nick the lens capsule, and we have a resident who's operating this case. We can nick that lens capsule, grab that, and you can enlarge that capsulorhexis and make it the size that you wish. And this patient's going to have a very nice outcome. Let's look at a few more interesting cases here. So here's a case, again, pressurized capsular bag, intumescent cataract. So in this case, making the incision, and I'm going to show you how it wants to run out. So we're just going to try do our Rexus quickly. You can see it is pressurized, and it wants to pull out. Look at the direction that I have to pull the forceps tips. I've got to pull it centrally so much just to prevent that thing from running out. And so you can do it this way, but it's a higher risk way. And the longer you take, the more the risk. So finally we get it done. Not the prettiest, but at least it's intact and around. You can see all the liquefied lens cortex that we got out of there. And at this point, we can just chop this nucleus up into small pieces and then aspirate it down pretty easily. So while you can use your standard technique of doing a capsulorhexis in an intumescent white cataract, it is tougher, it is higher risk, and because of that pressurization. So here's another one. Poking in with a needle and decompressing and getting out any of that liquefied lens material. So now making the main incision, and we have a resident who's operating, and we're going to try to get this Rexus done. And let's see if it starts to run out, just pull it in and finish the case quickly. But luckily in this case, you're able to complete a nice round capsulorhexis. Now, one thing important, as you depressurize that capsular bag, the fluid is also behind the nucleus. Now, here's a case where we stain out the trypan blue dye, and you can see the wrinkles in the capsule This is a fibrotic capsule after trauma. So you may have to use those micro scissors, so you may even have to use a cystotome or other instrument to help cut this capsule. Now you've got to be cautious because throughout the rest of this case, you may not have it fully intact. You may have weaker areas that want to run out. But in a case like this, we finally get it done. And even you can see now, sub-incisionally, we got to use that cystotome to help cut it. Now, what about a femtosecond laser? Well, sure, here's a femto case. Look, the capsule's stained, but it's actually incomplete. Sometimes when the lens material leaks out during the femtosecond capsulotomy, there may be areas where the laser energy was blocked and it's still adherent. So watch carefully. We'll grab with the forceps and you can see there's still a couple of spots, one there and one there. And so don't assume it's going to be free floating. Here's another one of the double Rexus technique. Again, the AC is highly pressurized, got the AC pressure very high. And we got that to keep the capsule from running out. And so now using just the cystotome, making a small little baby capsulorhexis, and that's going to give us access to be able to decompress the capsular bag. So again, getting that little baby Rexus done with just the cystotome. The only key here is to make sure there are no runouts. Once that is done, you saw the capsular bag was decompressed. Now we can make the main incision. So with an intact Rexus, even if it's small, it's just not going to run out. And so now we can go in that's decompressed, and now we can continue and make the full-size Rexus. Because again, we use that cystotome to make a small Rexus and also use that cystotome to decompress. And so we got the liquid coming out of there. And so now the second Rexus can be done. So again, the double capsule Rexus technique is very useful. And you can use that again, like this case at the beginning, or you can use it like the other case I showed you where you used it at the end after the IOL is inserted. Now here's another one. Look how much milk is coming out here. A lot of liquefied lens material. And so it becomes tough. So you have to keep injecting viscoelastic just to have a view. So trying to get that capsular bag decompressed, get as much of that milk out as you can. So again, doing a double Rexus technique here if you need to. And then now, as you express more and more of this, you may have to keep putting in viscoelastic just to give yourself a view. And so we can complete that Rexus and get the nucleus out and finish up this case. So again, a lot of lens material there. Here's another one, chopping this dense white cataract in the capsular bag, bringing the pieces up, looking pretty good. Nice chop technique. You can see the external view as well. So once you have a nice strong Rexus, then you can feel free to use whatever techniques you like, such as phaco chop or divide and conquer, stop and chop, whatever makes you happy here. And you can see this resident with these double angles is doing a really nice job of chopping up this cataract and emulsifying it pretty easily. So again, the danger in these cases, as you know, is the creation of that capsulorhexis. And that's where I think my take-home pearl for you today is use the technique of the double capsulorhexis and needle decompression if you need to. And here's another one. You can see it's very easy for us to chop this. And you're also wondering why to get such a beautiful blue dye stain, because I actually leave the trypan blue dye on the capsule for about 30 seconds. Makes for a pretty video. And then we can emulsify the cataract, take it out. So keep these pearls in mind, decompress the nucleus, get that liquefied cortex out, and you'll be fine. Thanks for watching Cataract Coach, and you know we have a new video every single day. And of course, it's all for free. Check it out.